The next topic is going to be on neutropenic precautions. This was actually recommended to me by one of the oncologists, Dr. Katona, R2, is offered to do that topic. So neutropenic precautions, effective infection prevention, or a waste of time and effort.
Hi everyone. Here's an outline for what I'm going to talk about today. I'm going to go through some definitions of neutropenia, talk about what causes neutropenia. We're all familiar with chemo, but there are other causes. I'm going to talk about costs, what the actual precautions are, go through a few efficacy studies, and then I'll give you my own conclusions, and then we can talk about yours. So as many of us know, neutropenia is when an absolute neutrophil count falls below 1,500. It's classified as severe neutropenia when it falls below 500. And this is concerning because it increases our risk of life-threatening infection, which I'm going to talk about in a little bit more detail. So chemo is kind of the biggest cause of neutropenia that we come across, but there are many other causes of neutropenia, including radiation, infections, autoimmune disease, an enlarged spleen, and drugs, including many antibiotics that we use on a daily basis. So when we think about costs, and these are not costs of using the precautions, they're the costs of actual neutropenia, so how much it costs to have neutropenic patients in the hospital. And these are from 2012, but there's no reason to think that that was an atypical year for neutropenia. This particular study looked at how many patients were hospitalized with neutropenia and how much that cost the healthcare system. So, 90,000 adults and 16,000 kids were hospitalized, and you see at the bottom how much that costs. So over $2 billion for adults and $439 million for kids. And these costs are just estimates. They don't take into account physicians' fees. They're really just what the bundled hospital costs are for neutropenia. So this kind of raises the question, this is a major cost to our healthcare system. Should we invest in preventing these infections rather than these costs that you see, the costs that we get on the other end of treating these people who are infected? And just so you know, this 91,000 number accounts for, there's about 35 million hospitalizations per year, or at least that was the estimate in 2012. So this is I don't know, I think it's around 3% of hospitalizations for adults are due to neutropenia. So just looking at precautions before I delve into neutropenic specifically, there's different types of precautions that we observe in the hospital. Airborne precautions we think about for tuberculosis with N95 masks and gowns, droplet precautions current right now with influenza, what we've been seeing, contact precautions, wearing the gown and gloves for MRSA, and then neutropenic precautions, which I'll get into now. So these precautions are really used in typically cancer patients, but now we know that there's a lot of causes of neutropenia besides chemotherapy, and they're really designed to kind of reduce the transmission of infection in healthcare settings in this patient population. So what does this involve? What are these precautions specifically? And I'm going to go through them one by one. But hand hygiene, which is by far and away the most evidence-based precaution we have. Standard barrier precautions, which we use when we go in and out of patient rooms. Infection-specific isolation, that has to do with air filtration measures. Avoiding plants and flowers in rooms and using certain kinds of foods, avoiding certain types of foods, and then basically just exposures. So making sure that people who are coming in contact with these patients are not necessarily sick themselves. I tried to figure out what the origin of these precautions is. Where does this notion of neutropenic precautions come from? And it really comes from this kind of protected environment concept, which emerged in the 1960s when a lot of these chemosuppressive agents were developed. Basically a bunch of experts sat down and decided if patients' immune systems are compromised, given the fact that they have cancer, then what must be best for them is to keep them in the most sterile, isolative environment that we could create. This kind of was a clinical notion that was developed, and as you'll see over time, it really hasn't been challenged to the extent that it should be. So we'll start with hand washing. As we know, hand washing is the most effective way to prevent infections in healthcare settings. The ideal is to sanitize your hands both before and after interacting with a patient. There's different estimates on how long you should spend doing this, and now we have the gels, and so that's a little bit different, but approximately 20 seconds. And compliance is a big issue with hand washing in general. Masks. So, using surgical or an N95 mask, if appropriately fit tested, is kind of the next precaution that we pay attention to, and it kind of bears the question, why does wearing a mask work when a lot of the particles that are being transmitted are so small? And the answer to that is really that the particles can kind of attach onto larger molecules like water droplets, and that's kind of how they're able to get transmitted. So in terms of barrier precautions, there's no specific gear that's required, but when nursing and physicians are in contact with body fluids, then we want to use standard barrier precautions, mask and gown and gloves. And then stem cell transplants need a private room. And then these full barrier precautions, which include airborne contact, and the standard precautions are really only for like SARS patients, larger epidemics. In terms of foods, we want to include, you want to see well-cooked foods, no deli meat, and then there's some discrepancy about whether raw fruits and vegetables are acceptable or not, but the consensus seems to be that as long as they're well cleaned and from a good source, then they're okay to bring into patient rooms who are neutropenic. In terms of ventilation, HEPA filtration and air exchange is really limited to stem cell transplant patients. And in these patients, you want to see the air pressure in the room to be positive compared to the surrounding areas. And then in terms of skin and oral care, this is all just basic hygiene practices that we observe, for most patients in general, but we want to pay more specific attention for these patients if we're following neutropenic precautions. Daily showers and bath, perineal hygiene, oral hygiene with oral rinses, etc. Plants and animals, this is kind of an interesting one. No dried or fresh flowers in the rooms, no pet visitors, no plants. And then lastly, healthcare workers and their visitors, we want them to be vaccinated, and if anyone is feeling ill or under the weather, we want to keep them out of neutropenic patients' rooms. So I just wanted to touch on, and this is like a whole separate topic, but since a lot of the studies that I found do talk about, or they kind of lump into the study that whether or not patients were on prophylactic antibiotics, I just wanted to touch on the fact that the majority of the infections that we see in neutropenic patients are really not from something that's brought in from the outside, but they're really from translocation within the patient's own gut bacteria. And so that raises the question, what's the role of prophylactic antibiotics? And I think in the hospital, when we admit patients, it's kind of a no-brainer. If someone's admitted for febrile neutropenia, they're always going to get prophylactic antibiotics. But how do we make that decision in febrile versus non-febrile patients, and which antibiotics do we use? And so, many of the studies. One example of a study was a meta-analysis of 17 randomized controlled trials that looked at a prophylactic quinolone, and it did reduce the risk of febrile neutropenia. So there is a role for antibiotics, and but figuring out when they are most useful is something that we have to take into account here. So I'm going to just go through 4 studies briefly, and there's a variety of studies on this topic, but keep in mind that the precautions that I explained differ by center, so kind of each hospital or healthcare system has its own set of precautions that is implemented differently, so it's a little difficult to compare study to study because different precautions were used, as you'll see. First study, and this is from 1975, Annals of Internal Medicine, looked at 64 patients with acute non-lymphocytic leukemia who were admitted for induction. And they were randomly assigned to one of 3 groups. The first group, patients were placed in a laminar airflow room with reverse isolation, and I'll show you a picture of that on the next slide. The second group received routine hospital care with antibiotics, and the third group just received routine ward care alone, no antibiotics and no reverse isolation. So I just thought this was interesting. This is from the study in 1975. They kind of depicted what the room looked like. And basically the visitors enter the patient's room like opposite they talk about how visitors enter opposite from where the bed is. Like you see the door opposite the bed, and then you see the sliding window counter, and that specifically is it's like a sliding counter where that's how kind of nursing interacted with patients. That's how they got vitals. That's how they did blood draws, is like through this sliding window counter. And then you'll see the HEPA filter along the right side. And another thing mentioned in the study is that all food that patients received in group 1 was well-cooked food, so no raw food at all, which I talked about earlier. And the conclusion was that the first group that was in reverse isolation had a decreased total infection rate, decreased number of infectious deaths, decreased time to first infection, and then any sort of fatal infection was delayed in that group. And these were all statistically significant results. So, here's one study that shows that isolating people who are, with neutropenic precautions and giving them antibiotics decreases infection and decreases mortality, okay? So moving on to the next study. So this is from the Journal of Clinical Oncology 2016, and it's a subset of a larger study of 629 children in Europe undergoing an AML trial. The study itself was looking at kind of up titrating chemotherapy in different groups, and then 339 children were kind of extrapolated from that larger group to look at infectious complications. And the specific precautions that they extrapolated from the study were whether these patients were, what foods they were given, whether they were raw, uncooked foods, whether they had interaction with pets, and whether any social contact, social visitors came in to see them. And basically, comparing these to the patients that didn't have these precautions implemented, there was no difference on fever, bacteremia, pneumonia, or gastroenteritis. So takeaway from this study is that whether patients that were given precautions, weren't given precautions, it really didn't matter. There was no benefit of these precautions on outcomes, okay? Different outcome than the first study, right? Study 3, this is from the New England Journal, 1981, and this looked at 43 patients who had severe granulocytopenia. 20 of the episodes occurred in 17 patients, and those patients received simple protective isolation measures. And then the 23 other episodes were in 20 patients who received standard care. So we're comparing simple protective isolation in neutropenic patients versus standard care. And these are extremely small studies, 40, 60 people, but there was really no difference in infection, incidence of infection, onset of first infection, or days of fever between the two groups. The reason I thought this study was actually really interesting is that in the isolation group, there was a 3-fold higher rate of bacteremia. So you might wonder why that is the case. And the comment from the study itself is that this bacterium originated from IV lines, and the thought was that there's so much effort among nursing staff and ancillary staff in terms of gowning and abiding by the specific precautions that actually tending to the medical equipment itself and IV lines was kind of deprioritized, and that was their best explanation for why this occurred. Last study that I'll go into in detail is from the European Journal of Oncology in 2003, and this looked at 81 patients with AML and 97 transplant patients. What they did is they basically stopped neutropenic isolation measures and looked at the outcomes of these patients over the following 3 years, and then they compared that to the 3 preceding years before the study when patients received standard isolation precautions. And this study, just like the past 2, had no differences in infection or mortality. So, there are other studies on this topic, and what they do have in common is they all have a pretty small N. These sample sizes are extremely small. So the sample sizes are small, and variability in terms of how precautions are implemented is widespread. And so, but just putting this in a table, I just wanted to kind of point out that the majority of studies that I found, and if you look at the red X, that's a total of about 200 patients, so not a huge number, who were studied with precautions, without precautions, looking at morbidity and mortality. Precautions did not seem to have any benefit. So as I mentioned, comparing these studies, there's definitely limitations because hospital practices differ, and how these precautions are implemented has a wide array of options for different hospitals. But it really kind of asks the question, do we need to evaluate neutropenia precautions at our hospital, or do we just need to think about this kind of on a policy level? Is this something that we need to revisit from the 1960s when these consensus of experts decided that this is the way that neutropenic patients should be treated? We're starting to see a trend in hospitals kind of starting to relax their policies, and those are mostly just opinion pieces that you can read about on the internet, where hospitals say, here's some data supporting relaxation of our policies, maybe our hospital should too. Whether antibiotic prophylaxis should be administered is a much bigger topic, as I mentioned, but one thing I do want to touch on is that implementing all of these precautions for patients does have kind of a social cost. It's not just a financial cost. There's not only a clinical cost, but there's also social cost to patients. It distances patients, you could see in that diagram, from caregivers and from family members. We're limiting visitors. It takes longer for caregivers and nursing and physicians and everyone to get in and out of a room when they have to abide by these strict practices. And if there's not actually any benefit, do we really want to continue doing that? And then, do costs matter? Does, there's not an unlimited amount of money for patient care, and so what do we want to prioritize? So just looking at future research, these are just some of the questions I had after doing some research for this talk. Which patients are more genetically infection prone? How does the microbiome play a role here? It definitely does. Are there ways to develop non-neutropenic cancer treatments? I'm sure that's all in the works. And then what is the role of other factors like menstrual cycle, age, gender, and ethnicity? Any questions?
I have a question about the general precaution, because I've heard different opinions. Like, for example, when somebody's on droplet precaution, doesn't it make sense that it's contact droplet? It's like kind of sequentially. And I've seen people just have droplet and it's just a mask and nobody was wearing a gown. So is that a thing that, or is it just different types of precautions completely? Or should they be implemented together, stepwise fashion?
I mean, I don't know about how it's a stepwise. I don't know the answer to that. I'll defer to Dr. Jose on that.
I think if it can be spread by aerosol, it can also be spread by the hands, is what they're trying to tell you with that. So you can't really isolate just respiratory secretions from what's on the hands.
And that's what I think, but I don't think we do that in the hospital. They just do the droplet.
I was just going to say, so thanks for the talk. That was an interesting topic. The culture of infection control, I think, has really changed over this last 20 years, and certainly over the last 50 years, for all patients, so not just for the neutropenic patients who are kind of handled with special gloves. So I think that's just one thing to think about as you look at what the data says for the last 40 years. The other thing, though, to keep in mind, is just an important part of the conversation is the outcome for these leukemic patients and their risk of, no matter what we do, having an infectious complication is tremendous. And so the intangible here that I think, and I acknowledge the goal of this conference is really around the evidence, but the intangible here to some degree is also supporting the patient, and the number of times that we don't necessarily need to put on the protective gear, but we do so because the patient requests it, because it lets the patient feel that everything safe is being done. I think that plays an important role in whether or not we put on those masks and the gloves. And it's not evidence-based, but I think it's part of the conversation.
Any other comments?
A question. On the study that you showed where antibiotics prophylactically decreased episodes of fever, was there, other than the fever, was there a survival benefit or anything like that?
Are you talking about the first one?
I think it was the only one where you showed a decrease in a benefit to the, it was with antibiotics.
Just fatal infection, not death. Yeah, so death, fatal infection.
It did decrease mortality?
Yes.
From infection.
From infection, mortality from infection.
But remember, this was a study of 64 patients, and they were randomized into 3 groups. So you're talking about 20 patients. So it's a pretty small study, as most of these were, although a few of them had several hundred patients. All right, so we'll get to the voting. Neutropenic precautions are effective in preventing infections in neutropenic patients. So how many think that this is true based on the evidence? How many think that it's plausible still? So a lot of people, pretty much everybody. Wow, that's probably the first time that's happened. And how many think it's definitely a myth? Okay, interesting. Well, since it's a democracy, I guess we're going to say that this was plausible. So I don't think we've seen this one before.